Okay, first a thank you to Bev Roeder for the invitation to speak tonight, and to Greg for allowing me to be on this panel. I know some of you from Providence Sound Home Care. I was the director of hospice there for many, many years, and I've been leading the public policy efforts at the Washington State Hospice and Palliative Care Organization for about 5 years now. I recognize one of you from Cancer Committee at St. Pete's, too. All right, I'm going to go through, I felt like I would be remiss if I didn't go through some of the fundamentals, and so I'm going to cover that. Bev thought there might be some opportunity to ask questions and such about the basic benefits as well. I want to just mention the organization that I work for, and it's a 501c3 nonprofit educational organization. So our primary focus is competency and education for hospice and palliative care professionals. We also support provider members, and we have 100% membership. One of our members, actually, Julie with Assured, is here tonight, so a shout out to her. We have about 40 provider members that are serving patients for hospice services and palliative care within Washington State. And we have 7 straight palliative care programs that are members as well, serving 7 of our counties.
So when you say provider, are you talking about individuals?
Programs. Programs, thank you. Provider members are programs to us. Okay, so I think everybody's familiar. Some of you, tell me, you have some familiarity with the hospice benefit? Because I want to move kind of quickly. Okay, good. All right. So it's a holistic concept, patient-centered, patient-driven plan of care. Basic philosophy has always been that it does not prolong life, and neither is it to hasten death. We do need a physician order for services to evaluate for hospice, and a physician to sign the certification of terminal illness with a prognosis of 6 months or less, to the best of their knowledge, should the disease run its normal course. That's the language in the regulatory. Okay, and I think you're all aware, but just as a baseline again, that hospice serves the patient wherever they call home. So we can cross a lot of settings: skilled nursing facility, assisted livings, adult family homes, and the newest are hospice care centers. As Greg mentioned earlier, we've got the interdisciplinary team model of care. And again, I think you're primarily familiar with it, but I do want to touch on that the historical roots of hospice were in volunteers providing the care. So when the Medicare hospice benefit was developed in 1982, they retained the requirement to have 5% of total hours of the care provided by volunteers. So, and again, certified hospice programs then are surveyed to that standard and regulation. Comfort therapy programs vary significantly between our hospice programs based on funding and the availability, since there's no separate reimbursement for those services. And so those therapies are complementary in the true sense of the word, and usually have to be supported by donations and foundation funding. Generally, we found that massage therapy is the most requested comfort therapy. Okay, and again, just to establish that we have 24-hour availability of nursing services in particular, and that is for advanced pain and symptom management. The nurse is on call to triage and to make a visit as needed. The rehab therapies are available, and in practice that I've seen, the therapy services are beneficial, especially when the patient experiences a significant change in functional level. Grief support services, again, for anticipatory grief, working with the family, and also then for up to 13 months or more after the patient death. And generally, grief support services are available to community members whether they have been served by a hospice or not. So there's that community need that is met as well. The plan of care, again, has to be established and reviewed by the medical director, and then the hospice team is required to review that plan of care every 15 days minimum, and that's in the regulations. In facility-based care, the hospice plan of care has to have common problems and goals and an integrated plan of care with the facility, between the facility and the hospice program. And the plan of care can and should look at role delineation between the hospice staff and the facility-based staff. Provides better clarity. Okay, so who pays for hospice care? Generally, Medicare and Medicaid and private insurers reimburse hospice care on a daily rate, or a per diem as we call it, and that averages around $160 a day. Medicare makes up between 80 and 90% of the hospice patient population nationally. Medicaid in Washington state mirrors the Medicare benefit, and that averages generally 5 to 7% of the patient census in most of our Washington hospice programs. The per diem is for a bundled set of services that includes durable medical equipment, supplies, and medications, and it's fairly all-inclusive for the patient's needs based on the terminal diagnoses. There is no separate reimbursement for home visits that are made by all of the members of the interdisciplinary team, or for grief support services or any of the other things that we've discussed. It's all in there in that flat daily rate. So those of us that have administered hospice programs, it is a balancing act that you do, but it can be done and done well. It's actually one of the best models for looking at bundled sets of services that exists in the current healthcare system. That's what I always tell the legislators. Okay, so levels of care. Again, just back to basics, the routine home care, inpatient respite care, which is just for family caregivers, not for paid caregivers, and general inpatient care in the hospital or sometimes in a skilled nursing facility, and then continuous home care, which is for up to 72 hours of care, primarily in a period of crisis. Usually it's a pain crisis, and at least 50% of those hours have to be provided by an RN, and it has to be a skilled need, and it's strictly regulated, and to be honest, it's often very difficult for the hospice to meet the requirements and to deliver and staff that care. So you don't see it happening very often. It's like 0.1% of the days of care for a lot of hospice programs. The face-to-face encounter rule, you may be familiar with that with home health as well, but I wanted to talk a minute about that and also about the benefit periods. So there are 2 90-day benefit periods followed by 60-day benefit periods as long as the patient continues to qualify for services. The reason that's significant is that at a point in our history, going way back, there was a limited benefit, and there was also a period of time when if you went off of hospice care in the 4th benefit period, you could never access those services again. And so just to dispel any misconception that that still exists, it does not. So it's, again, we've got the face-to-face requirement where the patient is looked at each benefit period, starting with the 3rd period, but that doesn't occur. However, private insurance benefits vary, and there may be a 6-month limitation on a private or a commercial policy, or a dollar amount cost cap to consider. So private insurance is different than Medicare and Medicaid. The face-to-face encounter then it's required for a physician or an ARNP to see the patient, and it can be completed up to 30 days prior to the start of the 3rd or later benefit period. And once that kicks in, then the face-to-face visit must be repeated every 60 days thereafter. And the physician or the ARNP then prepares an attestation and a brief narrative about the patient's continued eligibility for hospice care. And we've had that in place about 3 years. Does that sound about right? I think it's been about 3 years. So if the patient is deemed no longer eligible for care, the hospice does have to provide a minimum of a 2-day notice for discharge and allow for coordination of services before discharge, prevent any semblance of abandonment, right? The patient and family do have the right of appeal or a case review through CMS, and actually while I was a director, we had several families that did avail themselves of requesting and asking for an appeal of the decision, the discharge decision. Sometimes that can be looked at again, and sometimes it just cannot. You know, ultimately, you've maybe seen some of the research that shows that with the improved quality of life and the improved attention of the interdisciplinary team, patients often do improve and go off of their hospice benefit.
Isn't it true that people on hospice live longer than those who continue a scenario of chemotherapy?
That's some of the research that's been demonstrated, actually. You're right. Okay, so just to make sure that you know that if you're looking for a specific hospice program that serves a certain county, where basically the certificates of need are done by county, you can go to our website and there's a search feature there. And we also have a list of hospice care centers, palliative care programs, and pediatric palliative care providers as well. Okay, so just for your general information, within the Southwest Washington, Tacoma South, we have Franciscan Hospice Care Center. We have one at Hospice Southwest in Vancouver. There's one at Hospice of Kitsap County, and there's one at Community Home Health and Hospice in Longview, which is one of the longest standing hospice care centers in the state. Okay, so just some basic differences then between palliative care and hospice. And Greg has outlined some of these, so again, I'm going to try to move quickly. It's indicated for patients with a life-limiting illness, but there's no specific length of prognosis required, and it can be provided in concert with curative treatment. And again, Greg mentioned that I had another slide, but just to say that this slide illustrates the timing of palliative care along the continuum of the patient's illness versus the traditional hospice benefit, which is the last 6 months of the patient's illness. So, and again, similar in that it can cross different settings and such, so just so you're aware. Now this one, palliative care, hang on a second. The prevalence of palliative care programs in Washington State, which are higher in number than in the Western region or in the US on average. And this is as reported by hospital systems in the data collected by the Center to Advance Palliative Care, which is commonly known as CAPC. So in summary, and again, I know Greg has covered some of this, but the goals of palliative care: relieving pain and distressing symptoms, reevaluating goals of care, assisting with difficult decision-making, and then in addition, it has been shown that palliative care services improve quality of life and satisfaction among patients and their family, and it's been shown to improve transitions in care between healthcare settings. So before I move on, because I want to cover the primary part of is on transitions in care and some of the, we feel, very good work that we're doing around preventing of rehospitalizations. Are there any questions about basic hospice or palliative care? Yes?
Sort of the dovetail between life prolonging and palliative care. And I've not run into this for quite some time, which pleases me. But for a while there, I was running into things like, oh, you're CHF patient, you know, we're going into palliative care, so can we stop the Lasix and the lisinopril and the beta blocker because, you know, those are life prolonging. I say, no, they're keeping the fluid out as long as
right, symptom management.
I mean,
Yeah.
yes, they also,
Yeah.
it's the latter two have been shown to prolong life, but that's not why we're giving it to them. Now that I've done the referral, we're giving it.
Mhm.
And that challenge seems to have gone away, which is pleasing.
Yes.
People seem to get it.
Yes, and I think the lead into that was when we had a movement, I don't know, maybe 10 years ago for open access, and I know I did a lot of education about that then, crossing a lot of groups, but the hospice movement has been more in embracing keeping some of those treatment protocols in place that actually encourage quality of life as well. Yeah. Yes.
So I'm a little disturbed by a slide at the beginning where you discussed the hospice team. And the first thing was the medical director, and then parentheses with the primary care provider. And my concern is that when patients go to hospice, and frequently the primary care provider is excluded, unintentionally perhaps, from the care team. And I see your slide going exactly to the same problem that primary care providers see.
I think Greg can speak to that as well, but in my experience as a director of hospice, we had a real mixed bag of whether the physician, the primary care physician, wanted to stay involved in the care, and some actually wanted nothing more than for the medical director to take over the care. And so no intention to say one way or the other, but just to reflect what we have found to be common practice. Greg, can you speak to, since I've been away for 5 years into policy?
There are some geographical variations as well. I actually ran some stats recently to figure out with Providence Hospice what percentage of patients have been taken over for care by the medical director. It's less than 5%.
That's good.
Consistently. In
That's
some
good.
areas of the country, it's almost 100%. Think of the hospitalist movement or what happens in nursing homes. 15 years ago, we all managed our own inpatients. Then we figured out rotations that we could have one of our group doing the hospital care, and then we finally threw up our hands and turned them over to hospitalists. There's some movements like that across the country in hospice. People are busy. I'm getting more and more calls from office-based practitioners say, I can't handle the paperwork, the medications, the complexity. Could you take over? And we're not currently staffed to do that. And philosophically, I would rather the person that's managed that condition and knows that patient continue with them in this stage of the journey of the care rather than taking over. If the nurses and the hospice medical director are doing too much of your care, push back. Because then as a medical director, I get a lot of calls because I'm easy to get a hold of. They know my cell phone number. And I often say, have you talked to the primary doctor? Well, not yet. You talk to them first and then we'll talk.
Yeah. Thanks. That was a good question, though. I think it's important to clarify. And from the patient perspective, they were often upset by the fact that their primary care provider wasn't following them anymore, if that were the case. So I know from the patient family's perspective, they would much prefer to maintain that relationship. Yes?
In the politics of medicine, it's interesting if you're a rural healthcare clinic, you get no reimbursement for managing hospice.
Mhm.
If I'm a Medicare provider and I provide so many, I forget the number, within 1 month of supervision, I can get paid for that of supervising hospice or home nursing. As a rural healthcare provider, once I refer to hospice, I can manage the patient, but I don't get paid for it.
Interesting. Huh. We'll have to talk about the regulatory piece of that. In fact, I met with rural health at the Department of Health just recently, and that's something that wasn't brought up. So, thank you. Okay. Yes?
As a point of clarification, on your slide, you had a continuum for palliative care merging into hospice care. So is palliative care somewhere in between home visiting nurses and hospice? I mean, when we order, for instance, palliative care, clarifying the distinction there, so when we order, how we order it and so forth.
Well, it's a complex answer, I think, because it really varies what the, in fact, you're going to see some models of palliative care in this next part of the presentation. but palliative care programs within home health are maybe what you're describing. So when you're ordering home visiting nurses, you're ordering a team of palliative care professionals in some home health agencies. They're embedded in the home health. Is that what you're?
Well, let me give you an example.
Okay.
I have a 68-year-old who's got end-stage lung disease, who's in the hospice for a while, but she's done really well. But
Okay.
she is still very debilitated, oxygen dependent, and can't get out of her home and so on. And so, just so that I can understand the distinction between hospice and just home nursing care, or really is there a distinction?
Well, some of it is in the home health benefit, and of course that's evolved through the years as well. And the patient has to be homebound and some of the other criteria that go along with home health. And so there is that gap in services that we're all trying to figure out how to meet. But there's definitely, I think what you're describing is the gap in services. So they no longer qualify for hospice care. What do the palliative care programs within the local home health providers, what are they able to give in the way of resources? If they can have it on the home health benefit, at least there's some reimbursement for it. But some of the palliative care that's being provided across the settings, there is no method of reimbursement other than physician or ARNP billing codes. And so those are some of the challenges that we're facing. So I think you've captured some of the gaps. I will show you some examples, though, coming up in the presentation. And I know we're I know. Maybe what I, Go ahead. Okay. I wanted to tell you about some work that we're doing on preventing readmissions, but it's another big chunk of information, so maybe I'll just highlight some of it. All right. And maybe just the outcomes. So to tell you that we've been involved with the Washington State Hospital Association, and they have some groups that are working on prevention of readmissions. So the steering committee and the Partnership for Patients Readmission Prevention Work Group. And what we've been looking at is developing the role of palliative care in preventing readmissions. And so I wanted to share some of those highlights. My understanding from speaking with Bev is that you assume some of the risk for some of your plan for readmissions, and yeah, so I guess so that we have time for the role play, I'll just highlight some of the outcomes that they've found, and you can always go back or the resources and tools perhaps. Okay. So I wanted to point out, and I brought a copy of this, but I can send this to Bev online as well, and I've got a copy for you. But essentially a good resource that was identified by the American Hospital Association and the CAPC Center that I mentioned earlier. And there are a couple of things within it. It's a great publication, but it has the role of palliative care in the hospital, improving quality of care and reducing readmissions through palliative care. And then in Appendix D, there's a palliative care screening tool that's been utilized. And essentially, it identifies triggers for a palliative care consultation. And it's completed within 72 hours of hospital admission. And then the presence of 2 or more triggers then is a positive screen. And I'm going to just jump through this because we're so limited in time. So some studies out there that show that 30-day hospital readmission rates can be lowered through use of palliative care. And I was going to highlight those. But and then this is, so this was the results of the particular study from USC. I believe this is the USC, yes, School of Gerontology. And just looking at the post-discharge services and the percent of readmission rate. So hospice was 4.6, palliative care was at 8, skilled nursing facilities were at 24, and no follow-up care in the home was the highest readmit rate. So again, just looking at the relationship between having had the consult, whether it was done by an RN alone or an interdisciplinary team, and that was found to be significant as well, that the interdisciplinary team provided the palliative consult. This is looking at different palliative care models within Washington State and some of the work that they're doing in preventing of readmissions. So again, this is information that I can get to Bev and maybe she can disseminate through email, but. Put it on the website. Okay, all right. Maybe you're familiar with Dr. Eric Coleman's model. And again, it's about managing the patient's medication reconciliation, their personal health record, identifying red flags, having a sick day plan, and then as well making sure that the follow-up appointments are made. Those may sound basic, but he spoke nationally on the subject, and he's considered the expert. So multi-care Mary Bridge, just about pediatric palliative care and looking at reduction in emergency room visits. Bridges Palliative Care is kind of a program like you were talking about, a GAP program. Peace Health Southwest in Vancouver offers this. They have an outpatient palliative care RN and then other team members that help to deliver that care until if and when they need to go back on their heart connections. This is specific to cardiac patients and diagnoses, but they can go back on hospice quickly then if they become eligible again. So that's a GAP program. Providence has some partners programs they've done with the Everett Clinic. And results again, significant reductions in, those are just, that's some of the data, right? Nope, okay, wait a second. Well, there was, anyway, again, significant reductions in overall contribution to prevention of readmissions. And then Harborview's as well. And they have developed, in their hematology oncology clinic, they have a palliative care service, an ARNP, and they have 24-hour availability of palliative care specialists, and they provide primary care and palliative care together in their outpatient clinic. So that's kind of a blended model there. But again, they found 20% reduction in hospital readmissions. So. Okay, I think that, and these are my colleagues that have worked with me on some of these projects, just acknowledging that I didn't do this in isolation. Okay.